You're going live.
Yeah, we're live.
Right.
वास्तु ने आके यहाँ गप्पे करनी है? Let's talk about that live before it
We're live
starts.
now.
No? वास्तु ने आके यहाँ गप्पे करनी है? Let's talk about that live before
We're
it
live.
starts. No? वास्तु ने
Anyways,
आके
this
यहाँ
is
गप्पे
done.
करनी है? Let's talk about that live before it
Live.
starts. You need to make that volume low, don't you? Yeah, let's do that.
I'm happy without it.
No. That's the thing, right? So now, but really tell me, like,
What are you doing?
how do you actually become good at all this? Building this. Like, I'm no good with tech. So how do you become good at all this webinar stuff and this organization?
This is being recorded.
Yeah.
Just sit there quietly. Don't talk. This is YouTube live.
Mm.
Well, can we not edit it, right?
Hello, Aisha. Can you hear me? And can you see the screen?
Okay.
Aisha? Sadiqur, can you hear me? Oh, yes, I can. Thank you. I'm guessing, Sadiqur, you don't have a mic.
Assalamualaikum, brother. Yeah, I'm here.
Got a mic.
Can you hear me?
I can hear you. I thought you were ignoring me.
Oh no, sorry. I've tried to unmute myself. Is this
I thought your purpose, like, you know what? I can't be bothered to reply. Did you see that post by on the chemist and druggist for the for Boots now also starting a private minor illness walking clinic?
No, I've not read that fully. I haven't opened it. I've seen it on my Twitter feeds, but I'm not actually read it fully yet. But I think you made a comment ago. Why are we doing it for £14?
I just want to know where that number comes from. Why £14?
Where do you think it came from?
Yeah, that's true. Like, you put it on there. Where do you think? But where's the rationale for 14 quid? I don't get it. Why could it not be like, I don't know, 13.99 or £15 or £20? But I guess they're all starting off. So I think it's going to eventually become the norm. That is.
But unless they want to undercut independents like yourself, isn't it?
Oh God, yeah. We'll have to reduce our price now then. I think it's really good for community pharmacy because it gives pharmacists options, and it's also going to give them, like, I think a lot more, what's the word I'm looking for? A lot more job satisfaction, because I think eventually this is going to become, really, really common.
Well, I think this is what pharmacists wanted to do anyway when they first qualified. I think it's now evolved from a tick box dispensing prescription checking. To be honest, technicians can do that. Pharmacists are more than capable of doing these minor conditions and dealing with them themselves.
Yeah.
And obviously, it's just unfortunately at this moment in time they're not getting any funding for that. So it's all script volume. But also, you and I know eventually it is going to have to be service based, and the stuff that you're doing already at your pharmacy is going to become more and more commonplace. But I just hope that pharmacists don't undersell themselves either, because even though to train yourself with acute conditions, it's not easy anyway, and it does take a lot of time to spend, and that should be rewarded as well as the risk involved. So yeah, that if it's £14 per consultation, that's nowhere near enough. I mean, how much is NHS paying for a 10-minute GP consultation?
30 quid.
30 quid, exactly. So it's got to be similar to that ballpark figure.
I think anywhere in the region of £20 plus,
Yeah.
I think is acceptable. So 25, 26, 20, £25. But I think beyond £30 is a lot. I think if you go beyond £30, I think it's going to get expensive for patients as well to pay for it. But certainly, I think anything less than £20, I think it is what it is.
Well,
but I don't think it's, I think it should be more than that.
Obviously, it should be more than that, but I think pharmacists, prescribing community pharmacists, they've already started doing it £10-15. That's on average what I'm hearing for those that are offering those private walk-in services. And obviously, if Boots are now doing £14, then unfortunately, I fail to see how community or independent, I'm going to charge more than £15 because of the competition. And obviously, how many Boots branches are there up and down the country? So but obviously, at the end of the day, it's your customer service, which is going to be unique to you.
That's right. Your knowledge base, how good you are with the knowledge itself. That's all going to make a huge difference.
Even if you charge more, patients know if you know what you're talking about, they'll come back, guaranteed. So that's got to be your unique selling point.
No, you're right. I'm gonna see. Okay, can you see? You can't see these questions, can you?
I can see you doodling.
With questions?
Is it questions? You're drawing road humps or something.
Okay, no, that's fine. There, you can see him doodling. That's fine. Okay, so you can't see the questions. That's fine. That will come up. No, these are actually not road humps. These are actually my version of trying to explain something. So hopefully it'll make it
very good.
A lot more sense. I was actually trying to draw the. We've got 4 minutes. I was actually trying to draw the ear with this. So because I'm using a mouse and it's not the same, but I'm gonna.
Can you not use like a pen or like a stylo pen, or you don't have that facility yet?
I need to get the boys to basically sort that out. They're gonna basically sort that out for me.
Okay, obviously using the mouse for anything, to be honest, is pretty difficult.
Yeah, let alone trying to do these anatomy drawings.
What is it? Is it a Mac or PC? You got trackpad or something?
This is what is this? Is like a Mac PC. I don't know. It's like a Mac PC. But
okay, so you don't use a trackpad.
I ain't got a clue what a trackpad is. I'm guessing you're talking about that thing that connects and you can draw there, right? So
instead of using a mouse, it's like a square, and you just use your finger. And there's so much. Trust me, once you use a trackpad, you'll never ever go back to a mouse.
But did you see the difficulty I had with Paul trying to get that YouTube video? Thohidul must be thinking, what a guy. This guy cannot make that. And it took me ages just to get it live. So he must be thinking, what is wrong with this guy?
The man can dissect a human body, but when it comes to allowing YouTube video to be accessible to other websites,
everything falls apart right there. It's like, he must be thinking, what is wrong with this guy? Everything is just falling apart. And all I've asked him is just make it go live.
Yeah. Can't be good at everything, but
the document that you had, is that now available for everyone? Was that sent to you by the RPS?
No, that's it's publicly available, because I think that document's for public, so you don't need to, because I'm not an RPS member and I can still access that document from that RPS website.
And it's 3 years, that's confirmed, right? Because I read 3 years.
I think they've actually say a bit longer than that. I think it got reduced to 3 years.
Whoa, they were thinking longer than that.
Yeah. I think that in the consultation phase, they're thinking. I think one of my contacts, I think she was on the original panel back in Wales. Let me see. Yeah, they lost the 5-year argument.
Oh, I don't know about 5 years.
Because obviously in the steering group, what's her rationale? The point that as pharmacy is specifically generous qualification, then 3 years is too soon. Similarly, the teaching qualification was not considered essential, but worded as must have competency.
If that was a teaching qualification, that would mess it up. There's, at the end of the day,
no one's going to have.
It doesn't require a teaching qualification.
I think experience. To be honest, I think experience is enough if you've got experience of teaching and giving feedbacks to your mentees. But I think it does seem like it's still more stricter to be a DPP than to be a doctor DMP.
Oh, I should be an artist according to Aisha. An artist, yeah, I can. Artist, right? I should be an artist. Yeah. Yeah, I'll try. I don't know about that.
Okay, what's it? What?
I should try it. An artist. Did I even spell that right? A-R-T-I-S-T. Yes, I did. Sadhguru, you need to check my spelling, bro, because sometimes, you know, in the heat of the moment, things go wrong.
Oh, don't worry. I
Then
think
it's
Toy does
messier.
similar, and he blames it on spell checker. Autocorrect.
You know what? When I was actually writing up these slides, I thought if you Sadhguru saw this, he'd be like, you know, what is wrong with you? There's basic. Wait, right? Is it half? How much
It's
time have I got left? According to this, the
it's
time is
7:30 on my phone now.
it 7:30 on yours?
Yeah.
Right. I think we should start.
Okay.
Yeah. Can you see the? I'm gonna unfortunately have to mute you, bro. But can you see the slides, right?
Yeah, I can see the slides on the left hand side. Yeah.
Brilliant. Okay, great. Okay.
Cool.
Good evening, everyone. Thank you for being here today. I want to start off by thanking everyone for getting in touch and kind of like just giving me feedback, which is extremely important for me to kind of make this work and you know, more importantly, for you to get the best out of the learning. So thank you for that. Today's session is going to be extremely, I think, interesting and important. And I want to start off by basically get the brains in gear and giving you some questions. So I'm going to put this poll out there. Let me know if you can't see this, and you need to basically answer these questions. Sadhguru, just on the chat, can you just confirm you can see the questions? No? Oh, perfect. Okay, brilliant, great. Right. I'm going to give you literally everybody has, so you have a minute to go through those questions. And we have now 30 seconds gone. Let's make it a minute and a half. And I'm guessing you can see all the questions. So the first one asks you, in order to make clinical diagnosis, which of the following must you have a sound knowledge of? The second one is, what is epistaxis? Which one of the following is gram-positive bacteria? That questions. Otitis media is an outer ear infection, true or false? A perforation in the tympanic membrane is a complication of. The tragus is an important landmark. You need to scroll down as you answer the question, please all. Okay, fine. Thanks for that. Right, I think people are answering. There's only one that I thought was a bit ambiguous, so I just want to make sure I've done it right. The diagnosis of acute otitis media does not always require, that's fine. Master, that's fine. Discharge. Okay. What I meant by discharge from the ear can be any one of the following. So it could be any type of discharge if you're not sure. Earache can be caused by any of the following. Right. Not everyone, I think, viewed the questions, but literally we'll give it one more minute. One more minute. So you have 40 seconds. So can everyone please attempt the questions? It's for your learning. It's going to make it easier for you guys. $15 seconds left. 8, 7, 6, 5, 4, 3, 2, 1. Perfect. Okay. Let's have a look. All right, so let's go to the first question. And it says, in order to make a clinical diagnosis, which of the following must you have a sound knowledge of? Is there anyone who actually would like to answer this question? Anybody would like to answer this question, kind of explain why? Bobby, do you want to give this a shot?
Sorry, say the question again. I missed that.
The first question is, in order to make a clinical diagnosis, which of the following must you have a sound knowledge of?
Okay, I can't see the answers, but I'm vaguely remembering. I thought it was all of them.
Yeah, spot on. Thank you. That's right.
Yeah.
So thank you, Bobby, for that. So yes, you need to have a sound understanding of all of the above. And today the aim is basically to demonstrate that. That if you don't have a sound understanding of your anatomy, your physiology and pathology, it's very, very difficult for you to go ahead and make a clinical diagnosis, because anatomy will allow you to name parts. Physiology will allow you to understand what those parts do. And pathology, which includes histology, microbiology, histopathology, is the natural cause of disease and what causes the diseases. And it will teach you what the likely kind of outcomes of the diseases are. So, you know, you need to have a good understanding of all of these to be able to make a clinical diagnosis. And fantastic for the epistaxis, that is a nosebleed, because we're going to briefly touch on the following to do with the nose. That's an important one. So you might see that in your pharmacy, so we can discuss that. Well done to everyone. You got that right. This is a kind of like an interesting, which one of the following is a gram-positive bacteria? Who would like to give this an answer? I'm just going to pick on anyone. So Bharti Patel, can you hear me? I'm not sure if you can. Fine, let's go with Sadiko, you can hear me. Which one did you think it was? Sadiko? Okay, I think it plays about a bit, but if you are eventually able to speak, let me know. But in any case, so this is something, write it down, commit it to memory, right? So gram positive and gram negative, it's all to do with kind of dividing bacteria. So there's many ways that you can actually put bacteria in a platform, but the easiest way seems to be this gram stain, where they get like a color, and if it changes into a particular color, that the color, you know, like a blue color, for example, and it does change blue, then it's gram positive. If it doesn't change blue, then it's gram negative, whatever the color is. So it doesn't really matter what they use, but they use, I think, normally crystal violet. And what you need to remember is this: Streptococcus, write it down. Staphylococcus are gram positive, and you will be seeing them all the time in your practice. Streptococcus, Staphylococcus, 2. In addition to that, you have Listeria, Cyanobacterium, and there is another one which I'm going blank. There's one more that is also another gram positive, but that's literally the 4 that you need to remember. Let me quickly just bring that up, because that's going to really help you. And I remember and I memorize it all the time. And as a result of that memorization, everything else is gram negative for me, because it's so easy to memorize. So let me tell you what it is. Which was the last one? Let me just quickly go through that. So it is, okay, so it's Streptococcus, Staphylococcus, gram positive, Bacillus, Clostridium, Cyanobacterium, and Listeria. So I'll write it down, or on the chat, so you can all quickly, I'll write it down. Streptococcus, Staphylococcus, Bacillus, Clostridium, and Cyanobacterium, and the last one is this Listeria. This is broadly speaking. So there are others that are like mixed, but just remember them: Strep, Staph, Bacillus, Clostridium, Cyanobacterium, Listeria. If you remember these, everything else is normally gram negative. So Haemophilus influenza, Pseudomonas aeruginosa, now you've got the answer. So most of you got that right, 70%, which is great. Otitis media is an outer ear infection. false. Otitis media, otitis means inflammation of the ear. Media means middle ear. So it's inflammation of the middle ear, which is not the outer ear. A perforation in the tympanic membrane is a complication of. So again, the middle ear, we're going to go through this again, so it's not a problem. We're going to go through the middle ear you find in the ear, and it's a middle ear infection, and that can result in a perforation where the tympanic membrane will burst. It's not commonly associated with otitis externa, but certainly if that infection was to spread, it can go. It says, I think you need to change your setting to all panelists and attendees because we can't see what you're sending to the chat. Weird, because it says all panelists on mine. Oh, here we go. Okay, let me copy that down. You're right. Thanks, Aisha. Here, you should be able to get that now. Okay, so the next one is the tragus. Ooh, so the tragus is an important landmark for diagnosing which of the following: otitis externa, otitis media, cholesteatoma, or none of the above. Well, the tragus, which is basically, can someone just tell me you can actually see this? It's this bone, this little cartilage protection here. So it's the one that protrudes just before you get inside the middle ear or inside the membrane. It's this little, and I think some women and men might even get this, like, can get, I don't know, you can get it pierced. I think they do, but that's the tragus there. So here, if you normally have a feel of this and a patient mentions ouch or is tender, it's normally a sign that you're having a outer ear infection, which is otitis externa. So that's what it's a landmark of. So whenever you're going to see a patient and you feel here, and they mention, yes, it hurts, or if I touch any part of the ear, move it around, it's painful, it is likely to be an outer ear infection, which is otitis externa. The diagnosis of otitis media does not always require physical examination. Otitis media, as a rule of thumb, does always require a physical examination. There is no way that you can diagnose acute otitis media without looking inside the ear. And we're going to go through the complications later on. And should you do this, what you're basically, what you're risking. Because if they've got a perforation and you think, yeah, that's acute otitis media, and you prescribe, let's say an aminoglycoside like gentamicin, they could have ototoxicity. So you might have diagnosed it right, but there's a perforation there. And we know that, if that aminoglycoside was to get inside the cavity, that can lead to, severe toxicity. So that's why you always need to look inside. So the point I was trying to make was, if you have a patient who has a lot of wax and you cannot see through that wax, you should not be making a diagnosis until that wax hasn't dissolved. Or if you're not comfortable, refer. You always need to look inside. Don't take that risk. Do not take that risk. Mastoiditis can be suspected if pain is felt in the mastoid bone. Usually, yes. So the mastoid bone is here. So anybody who's got tenderness around here, and we're going to go through this, can have what we call mastoiditis. So just be careful with that. Just this part here. You can all feel it. Sometimes the mastoid bone is this bony projection, which is right there. Aisha, can you just make sure that all the demonstrations I've given you actually could see them and they make sense and I don't have to repeat them? If you need me to, just let me know, anyone, if it's not clear, we can do that at the end. Discharge from the ear can be a sign of all of the above. Yes. Your head, neck, your throat, your lungs, your heart, every part of your body is connected. There is nothing separate. We all need to stop looking at the human body separated. Unfortunately, because you've not done human dissection, it's hard for you to visualize this, but every part of your body is joined up. Your head, your neck, throat, chest, everything is one. Going back to discharge, in theory, when we look at the anatomy, any one of them can be discharged. Oh, I saw it. Is there a PowerPoint running? I can only see the title screen. Yeah, I'm only talking through the question. There's only a title screen at the moment. That's right. There's only a title screen at the moment because we're not going in the lecture yet. I'm literally just going through the webinar questions. So that's why. Can you switch your screen so people can see bigger? Right. Can I switch my screen so people can see bigger? From my side, it is bigger, so I'm not sure if I need how I can make it bigger. Okay, so you're kind of making it difficult for me by putting me in the center of this. Okay, right. So how do I make my screen bigger? What are you guys actually seeing? New share. Okay. Can I just confirm that you can actually see the screen first? And let me bring those questions back up. Right. So relaunch poll. Relaunching poll will clear the existing polling status, and you want to continue. Okay, that's going to get difficult. Yes. Okay, fine. Let's relaunch it, and I'll talk you through it all. I think that'll be the best way. So don't answer it. Let me go through it. So let's quickly start this. So in order to make a clinical diagnosis, which of the following must you have a sound knowledge of? Everything. What is epistaxis? It's a nosebleed. Which one of the following is a gram-positive? I've told you, I've listed it at the top before. So streptococcus, staphylococcus, bacillus, clostridium, cyanobacterium, listeria are all gram-positive. I think Sadekur is asking me a question. Right, okay. Yeah, that's fine. Can you see the, I'm guessing you can see the questions now. Okay, fine, you can see the questions. Great. Okay, so otitis media is an outer ear infection. No, it's not. It's an inner ear infection. And we'll discuss that in a second. A perforation in the tympanic membrane is a complication of, so the tympanic membrane is in the middle ear. Otitis means inflammation. It doesn't mean infection. Two different things. It means inflammation. Media means middle ear. The tympanic membrane is in the middle ear. So a perforation is a complication of otitis media, not otitis externa. Externa means external, so outer ear. The tragus is an important landmark. The tragus is here. So if you touch this and feel this, and there's pain as you palpate this, palpate means touch, it's most likely going to be otitis externa. A cholesteatoma, I'll go through that with you later on. Ignore that for now. The diagnosis of acute otitis media does not always require physical examination. Yes, it does, because if you don't look inside the ear and they have a perforation and you prescribe a particular antibiotic and there's a perforation there, that can cause ototoxicity. And we know that aminoglycosides like gentamicin, neomycin can cause ototoxicity. So that's really important that you're aware of that. Mastoiditis can be suspected if pain is felt in the mastoid bone. This is the mastoid bone. And any pain that's felt here, and we'll go through this again, is always, you have to refer this. And I'm not going to say it's a red flag, because I don't like using that word red flag. You need to understand why you refer this, because it can lead to infections of the brain and destroy other parts of the bone. So if you want to call it a red flag, call it a red flag. I do have an issue with using words like red flag. You need to understand why you need to refer this onwards. The reason you refer this onwards isn't because you're not capable of treating it. Anybody can be taught to do anything. Is because in the setting that we have, it's not safe. That's why you don't treat it. If you want to call it a red flag, call it a red flag. Discharge from the ear can be a sign of any one of them, because the human body is connected. The ears, the brain, the nose, the mouth. I mean, let me give you an example. When you, I think if you laugh too much, in theory, or if you cry, you can actually have the tears coming down, from your nostrils. Why? Because everything's connected. Everything is connected. So in theory, if you had blood, if you had clear fluid, or if you had discharge, it could be any one of them. That's why it's important for you to understand this now. Hey, everyone's got it all right. Actually, you have made one mistake, and that is that earache can be caused by the following. You can have eczema in the ear that can cause earache. And we'll discuss that later on, so keep that in mind. Is everybody clear on this? If anyone's got any questions, I'm happy to go through it quickly now, or we can at the Q&A. Right, let's crack on. Fine. Everyone's happy. Great. Right. Right, here we go. I thought I'd show you this, and it's really interesting that Boots have launched a private independent prescribing service. If you follow me on my LinkedIn or you've watched any of my videos, I've always said this is a future. I've always said it's an opportunity. And here we go. One of the largest chains in pharmacy is doing exactly that. I don't know why it's £14, but me and Sadiq were having a joke about it. And we probably know, yeah, exactly, cheap. My point exactly. I think that is cheap. And if you want my opinion on this, I wouldn't charge anything less than 25 quid, 25 quid, because I think you're devaluing the service. Secondly, if anyone feels that you can't compete with Boots, it will all come down to the level of knowledge that you have. For me, personally speaking, they can charge a tenner, but because of with the will of God and the support I've had and the knowledge that I have, I'm more than happy to charge 25 pounds, not £14. But certainly if you're starting off, that's a separate issue because that's a whole business discussion. But Bobby, I agree with you, that's a bit cheap, but it is what it is. But the point is, this is the future. Anybody who's in doubt should now understand that this has got to be part of what we need to do. Even as a contractor, it's going to be really important for you to appreciate this and start to change the mindset. I had a discussion yesterday with Michael, a good friend of mine, and I was explaining to him that sometimes when I sit down and I don't work in a pharmacy, I actually get anxious. I actually get anxious that I'm actually not doing anything, nothing productive. That's because I'm so used to working in the pharmacy and dispensing and doing that monotonous work that anything else I do outside that, I find it as, no, I'm doing something wrong, it's not productive. That's not true. Educating yourself, getting knowledge is the biggest asset that you have. And it's the most important tool that you have in the next couple of years. That is going to be extremely important. So invest in yourself. It's difficult I'm a contractor, and believe me, when I sit there and I'm not at work, I'm thinking, you know what, I'm wasting time. I should be working, I should be dispensing, I should be at work. This, educating myself and reading an anatomy book or making notes isn't going to pay my bills. What's going to pay my bills is that dispensing, but everything's going to change. Mark my word, everything's going to change. So you need to re-strategize, redefine your business model, redefine your working strategy as pharmacists. Pharmacists too, even if you don't own a business, you now have a business opportunity. By developing your skills, there's nothing stopping you to approaching these contractors saying, okay, let's set up a clinic together. I can prescribe what X, Y, Z. Let's do a 50-50 clinic. Why not? And I also think as a contractor that our payment model needs to work as well. I would no way go to work for any contractor and be paying the same wage. And I know some of you contractors might not like this. I'm a contractor myself, but I don't see why a pharmacist should be working for 20 quid an hour, 23 pound an hour and prescribe. I wouldn't do it. I think the rate, and if you want to ask me my rate, ask me in the Q&A, but I wouldn't charge anything less than what I think which is fair. But the company should also get benefit out that as well. And that is by you having good knowledge base, showing it and demonstrating it can work. Everyone's got a good chance. Contractors, pharmacists, prescribers, everyone has an opportunity. So anyway, we'll kind of move away from this now. The plan: complete anatomy of the nose, review anatomy of the ear, history-taking procedure. A lot of people have got in touch with me about my training program, what I actually do, and what training I actually offer. So I think it's only wise for me to touch on that because everyone's either got in touch with me separately or has asked me on the group, and then we'll have a question and answer session. So the ear, so let's look at the nose first. Quick review of the nose, and I'm going to make it very clinical, so what you need to know. The nose can be divided into two parts. The external nose is what you can see, and the internal nose will go through in a second. The external nose has these anatomical terms or these words. And remember, in anatomy, we love to name parts. Every part of your body has a name. And that's obvious because if you present with a complaint and Sadiq can't see the full picture. Sorry, why can't you see the full picture? Can you see the full picture now? I'm hoping you can see the full picture now. I wonder why that is. Is everyone having that trouble where you can't see the full picture? Okay, it's fine for you. Sorry, Sadhguru, it's not fine for you. Fine for well, tough. I think everybody else but you can see it. So you're just going to have to watch the YouTube video. You can zoom in and out. Oh God, I'm actually being schooled, I think, today with my kind of technology stuff. And I'm going to start to work on my tech. That's it. That normal anatomy, time for tech. So anyway, back to it. So you have the nose can be divided into external nose and internal nose. Do you need to remember all the anatomy? No, but do remember that the nostrils are known as the nares. Okay. And they're also known as the vestibule as well. You can also call it the vestibule as well. That's what they're also known as. The apex is basically the pointy part of anything. Like when you have a triangle, the pointy part is the apex. And here, this is known as the apex because it's the pointy part. And talking about the heart, if you ever have a look, the apex of the heart is actually here. So here's the apex of the heart, and the base normally sits there. That's why you feel the apex beat here. So if you ever go get a picture of the heart, you'll see that the apex, the pointy part, actually points here. You need to know that this part here is the septum. Sorry, let me go back. This part here is the septum. And that is it. That's the only part that I know. I know there's an external nose. I know there's an internal nose we'll get to. I know this is the septum. I know that's the vestibules or the nares. And I know that's the alar. That's more than enough. If you really want to be nice and, fly. Oh, okay. And then when you're pointing to yourself, it's not fully visible, but it's fine. Don't worry. Okay. Thanks, Aisha. But if you like, kind of like you could, that's the root, that's the bridge. So the root is between the two eyebrows. That's the root. And then you have the bridge here, this part here that forms like a curve. That's the bridge. But the only part you need to remember is that this is the apex. This is the nostrils or the nares or the vestibules, and that's the ala, or whatever you want to call it. That's it. Another thing you need to remember, and you can feel this quite easily, is that you've got bone here and you've got cartilage here. And that can move. So bone and cartilage. Bone and cartilage are specialist type of connective tissue. So please go search up connective tissue. Make sure you have a search about what connective tissue. You should all understand that there's 4 major type of tissues that makes everything. There's epithelial, there's connective, there's nerves, and there's muscle. That's the 4. Oh, so I've typed in connective twice. That's the 4 basic tissues that make up everything. Blood is also a connective tissue. Cartilage and bone is also of connective tissue. Go back and do your research on the 4 basic type of tissues that make up every part of your body, okay? So that's the connective tissue, why it connects things. Same thing with blood, it's connecting things, it's moving things in and out, diffusing things, so that's why it's known as a connective tissue. But that's all you need to remember about the nose. Quick summary, so you have the cartilage, bone, vestibules, nares, septum. That's it. And just remember that there's bone in this cartilage, and you can feel that. The real fun stuff is the internal nose. And basically what you have with the internal nose is 3 sections. You have the vestibule, which is this part here, the opening, and we've got hair there. That is quite important to understand, because if you've got hair there, we know that if the hair was to get blocked, there's a chance you could get an infection. So technically you could have like what we call a boil or a furnicle develop here. Just putting it out there. Once you start to go through, you have the respiratory part of the internal nose and the olfactory region. Olfactory is to do with sense. Sorry, it's to do with smell and taste. Yeah, we know that. So olfactory is sense, smell and taste. And we know that if you have a blocked nose, you end up getting this, you're lacking off, you can't, when you have a blocked nose, I can't taste anything. Why? Because that internal part of the nose is involved. It has these specialist olfactory receptors that go send messages and signals to the brain, active potentials and so forth. And that allows you to be able to basically smell and taste. Why this is relevant is because I'm just going to briefly mention about sinusitis, so you need to understand this. So the internal nose has vestibule, and the inner part we have hair. I've mentioned to you that technically speaking, you could have a blockage, could lead to an infection. As you start to work backwards, you have the respiratory region. What is the function of the respiratory system? The function of the respiratory system is pulmonary ventilation, which is moving oxygen in and getting rid of CO2. Why do we need oxygen? Because we need oxygen to make ATP. ATP is your internal currency. Your body doesn't use pound coins or dollars or Bitcoins or whatever they are now. Your body uses ATP. If you can't provide it with ATP, we need oxygen for that. It's not going to function. So that's, again, just a brief of what pulmonary ventilation is. It's moving out of CO2, bringing in oxygen. And this part here plays a really important role. And I'll discuss that in a second, why this part is so important. Have a look here. We have the auditory tube. Look at that. If you remember from last week's lecture, the auditory tube connects into the middle ear. So I just want to make a point that the human body is connected. So in theory, imagine if you had an infection of the throat. Could you get it out? Could you get an ear infection? What do you think? Yeah, of course you can. If you had an infection that was lurking here, is there a chance that it could go to the auditory tube and cause an infection of the middle ear or the ears? Yes, you can. So that's really important for you to understand that the human body is connected, and this also helps you when you do a history taking. That's why in history taking, we like to ask, do you have an upper respiratory tract infection? Have you had any infections? That's really, really important for you to understand that. I hope that's clear. If there's anything that's unclear, write it down and we'll go through it later on. If there's something you really understand, but just only part you have to remember, and I'm not being retarded or I'm not being, repeating myself again and again, is just to drill it home. And that is, we have the nose, we have cartilage, we have bone, we have the nares, which is known as the vestibule or the nostril, and we have the septum here. Okay, easy peasy. As we start to go inside the internal nose, you have hair, so technically that could get infected, and it could cause an infection. And the commonest skin infection bacteria is Staphylococcus. Staphylococcus is always gram-positive. We've got Staphylococcus, Streptococcus, Clostridium, I think it was Crino, Listeria, and Bacillus. I've written it in the chat, memorize it, write it down. Always gram-positive. Everything else from now on, Haemophilus influenza, Pseudomonas aeruginosa, gram-negative, gram-negative, gram-negative. Why you need to know this is how you're going to treat with an antibiotic if you don't understand the microbiology. Internally, we have these three parts here, the vestibules, and here, the respiratory region I'll go through with you in a second, why that's important. We have the auditory tube, which connects the throat to the ear. So that's why any infections you're having here can lead to ear infections. So just keep that in mind. Right. This is a really bad picture, and I'm really sorry. I really struggled to get a good picture. But let's have a look at this here. So when we start to break down the internal ear, we have these shelves. These shelves here, there's three of them. They're also known as turbinates, or they're also known as concha. And literally they're shelf-like projections, that's all they are. And why that's important, and I'm gonna explain this to you, is I'm hoping you lot can all see the whiteboard. And what I want to draw is this. Okay, so Sadika was asking me what I was doing earlier on, and this is my point, right? So here we go. Imagine if you didn't have, if we do the, sorry, let me go back. Sorry, let me go previous, and let me go back to select and text. Let me go back to share that screen. New share whiteboard. Share. Right, it's not letting me share that screen, which is really annoying because I can't really go back. Okay, you can see this. I should be able to show you the whiteboard now. There we go. Okay, fine. Here we go. Let's draw this. Right. So imagine if you didn't have these. I'm not gonna draw the internal nose, but what I want to show you is this. Have a look at this. So inside you have these shelf-like projections, and these. Oh God, why is it being awkward? Seriously, why does it not let me write? No, it's not going to let me draw. That's frustrating because either I don't know what I'm doing, which is probably the case, or let's try it once more. Now it's not going to work. Ignore it. Anyway, my idea of trying to draw you stuff is not going to happen, which is a real shame because I really wanted to test out my skills, but just ignore it for now. Anyway, forget it. I'll draw it here. Right. Can you all see this? No. Now? Not at all. It's going to be okay. Let me yes, okay. Fine. So I've drawn two lines. I've done a straight line and I've done a wiggly line. When the air comes in contact with the straight line, there's less surface area. When it comes in contact with the wiggly line, look at everywhere that it has to go through. It slows it down and it gives it enough time to get in contact with these turbinates. And these turbinates will basically add moisture back inside that air, regulate the temperature, give it enough time so it doesn't dry out the lungs. So I'll repeat, the reason why it's not just a straight line is because in here, it's actually wiggly like this. And the reason it's wiggly is because you want that air to basically get trapped inside here and spend ages, like a maze. So by the time it actually gets out, it's actually the right mixture. Because if that air becomes too dry, that can go in the lung, that can dry out the lungs. That's why your body is absolutely mind-blowing. And you have these turbinates that basically go up and down, up and down. The poor air's thinking, for me to get to A to B is going to take ages. I've got to go through all these different circles and wiggles and woggles, increases surface area, gives your body enough time to regulate the air temperature and put back moisture so it doesn't dry out the lungs. Is that clear? Is everyone clear on why that increases the surface area? Good. Yeah, thank you. That is why that's important. So your body is absolutely mind-blowing. It's mental how, whether you want to, whatever you believe in, I believe in God and how God has made the human body, it's mind-blowing. So that's part of the respiratory area. And what that basically does, it controls the temperature and it controls the humidity and makes out the right moisture, which is perfect for the respiratory system. Also, what happens is that these turbinates, when we break it down and show you on the next slide, I think, if you actually open these up, you actually have a space where these sinuses drain into, because these are basically airful spaces and what they contain is mucus, and that mucus basically lines up this here. Why do we have mucus in there? The reason we have mucus in there is because your body's smart. It wants to make sure that we can trap any dirt. It wants to make sure that the area doesn't get infected. So there's many reasons why you have mucus inside there. And these sinuses, which is basically a cavity, a space, these will actually drain into here and then go into the back of the throat. What do you think happens if they get blocked? Can anybody answer that in the chat? If these turbinates were to become inflamed and they block that drainage, what do you think is going to happen? Spot on, sinusitis. That's it. That's exactly what happens. And people will present with pain here. You've got frontal sinus, ethmoid sinus, sphenoid sinus, maxillary sinus. You can look into this. That's why it happens. Because if you block these up and these can't drain anymore, the mucus will build up and bacteria is thinking, perfect, we've got mucus, we've got all this gunk, I can grow in this, I'm gonna have fun with this. That's what ends up happening. I think we're gonna be kind of going past an hour, so I do apologize that it might be slightly more than an hour to cover this. So if you do need to go, it is going to be recorded. I would politely suggest that you stay because it's going to be great to have your question answered just to make sure that you understand what we discussed. So quickly reviewing: external nose, internal nose, apex, septum, vestibules, ala, nares. Clear. We go inside, you have the internal nose. You've got the turbinates, which are, and the reason they're called turbinates is because they're literally shelf-like structures. Shelf-like structures. Turbinates. And concha, same thing. You'll hear the word concha as well. It's exactly the same thing. And the reality is that with anatomy, everybody loves to write different names. They're all AKAs. They're all AKAs. In anatomy, you'll come across all these different words that mean the same thing. You know, fossa, cavity, sinus, just to confuse, as if it's not already so confusing, but then everybody, author will have his own words, means the same stuff. Shelf-like structures, why? We want to increase the surface area, we want to maximize the contact time, we want to regulate that air temperature, so your body is basically able to utilize that air without drying anything out. If these become inflamed, which is what you get in like rhinitis and so forth, these can block where these sinuses drain into, and then you'll have an infection. Straightforward. Wasim, you've got a question. What's the question? Unmute. Just raise your hand. Should I even let, this is my elder brother, I don't even know if I should let him speak. This is my chance of glory, but anyway, it's not letting you unmute. Just, you'll have to type it on the chat if you've got a question that's related to the webinar. But I hope that's clear. Right, so let's move on. And okay, this is important because you might have a patient who presents with a nosebleed, which is epistaxis. And look at that. Look at all the different arteries that supply the nose. Can you believe that? It's mind-blowing that, you know, your body is so complex. Look at all the different arteries that supply the nose. Do you need to memorize this? Probably not. What you do need to know, this structure here. This structure known as the Kesselbach's area, and it's known as the Little's area. And this is where, if you were to have a bleed, this is where it normally comes from, that region there. Does anybody want to give a wild guess what was to happen if you start getting bleeding that moves out of the nose versus going at the back of the throat? Which is more dangerous? Which is more dangerous? Bleeding from the nose or going backwards? Any guesses on the chat? Backwards, spot on. Why? Because if it goes backwards, it can go in the lungs, and that can lead to technically aspiration, where you're going to block it all up. So that is something really, really important for you to understand, that if you ever have a patient who presents to you with a nosebleed, and you've done like the commonest thing where you apply pressure here, don't tell them to lean backwards. Definitely don't tell them to do this. You know, can you imagine? The blood's going to go back. Not a good idea. You apply pressure here. You can't get like ice because we know it's a vasoconstrictor. Apply it on the, we could be anatomical, apply it on the bridge, or apply it on, you know, this part here. And see, in 10-15 minutes, if the bleeding stops, great. If it doesn't stop, they need to be referred. They need to be referred. And that's because this area here has an anastomosis. Anastomosis means when you have all the different blood vessels connect and they form this area. This area is also known as Little's area. Anastomosis, I think that's how you spell it. Anastomosis. So if you ever have a patient who presents with a nosebleed and you've put pressure here, you've put ice here, 10-15 minutes have gone, it's still bleeding, A&E. Not because you're not capable of dealing with it, it's because you're not at the right setting. You don't have the tools to deal with that. So I hope that's clear, but we could spend hours on the nose. It's absolutely mind-blowing. The human body is mind-blowing. You can discuss the anatomy. We could go to physiology. We could go to pathology. But just remember that here, you have hair. So technically, you could have like a furnicle or a boil that develops here. Most nasal infections are normally staph, which is a gram-positive. You could have bleeding in this region because of the anastomosis of all these different blood vessels that connect. If it's a posterior bleed, that's dangerous. Anterior bleed, probably not that dangerous. We know that we have these shelf-like structures, which are known as conchers or turbinates. Their role is to basically allow the air to have a lot of contact with them to regulate the temperature and the pressure and so forth. And we've also discussed if these areas will be becoming blocked, then the sinuses can't drain that mucus to line the mucus and you get an infection. That's the nose done for now without spending too much time. Yep, again, polyps, I'm not going to go into that because that will, we'll be here all day. But yeah, that's right. You can search up, have a look at everything else that can go wrong in the nose, but that's possible as well. So moving on to the next area now. Again, I just wanted to make a point of nosebleeds. And here we go. A posterior nosebleed is more dangerous than an anterior nosebleed. And we have anastomosis here. You've learned Little's area, or the, Kesselbach's pluxes. And pluxes mean just a group of things. So you can have a bacteria, you can have a bronchial plux, brachial pluxes of the nerves. You can have arteries. Pluxes just means when everything comes in and join. Same thing, anastomosis. Again, AKAs. Loads of AKAs. Pluxes. I mean, why can't they not just use it, stuff just joins together? Why does it have to be a pluxus? I don't know. And that's why it gets really annoying, because when you start reading anatomy, you read a sentence and then you have to go back and read the basic terminology. Okay, let's look at ear anatomy. If anybody can't stay longer, let me know, but I am going to finish this and we might need an extra half an hour, but this is important. A review. The ear is divided into outer, inner, and middle. Take a picture of this. The pinna, which is the outer part here, or this part is known as the pinna, all of this, okay? And the auditory canal is also known as the external acoustic meatus, again, AKAs. And that up until the tympanic membrane of the eardrum is known as the external ear. So we have the external ear is pinna, and auditory tube. That is the external ear. So if you ever see otitis externa, it's an infection that's happening here. Middle ear infection involves the membrane and the eustachian tube. Inner ear infections normally are to do with sound, balance, because we know that the ear has two functions. And the functions are balance and sound. So technically an infection can cause any one of these. So I hope that's made an ear. Otitis means ear, media means middle ear, that means all of this area. Externa means inflammation of the outer ear. So otitis externa, otitis media. I hope that's clear. And we've gone through the functions as well, and that's a review. What do you need to remember? This is the pinna. This is the auditory meatus, or the external auditory meatus. You need to remember that you have the tympanic membrane. You need to remember the different bones that are here. Can't stand these people that go in and out of this place. Next time we're going to have to ban them. And you have the eustachian tube, which is here. This is that tube actually that connects into the throat. So if you have a throat infection, that can cause a secondary ear infection. That's why whenever you take a history, you're always going to ask, have you had any throat infection? Why? Because if they had a throat infection, it would make sense why you're getting the earache. And then we have the inner ear, which is all to do with balance and to do with hearing, to do with sound. I'm hoping that's clear, because some people found it was quite rushed last time, so I hope that's clear. If it's not clear, just let me know in the chat. But that's you need to memorize this, guys. You gotta memorize this. There's, I can only explain it as much as I can. That just needs to be memorized. External, middle, internal. There's the external ear. Here you go. What you need to remember here, learn the tragus. tragus. Learn the tragus is this part here, because this is a landmark. When you touch this, can you see the tragus actually literally sits what we call anteriorly to the tympanic membrane. If you get your finger and put it inside your opening of the ear here, just this part is the tragus. So if you touch this and they've got pain, that's one of your landmarks that you might be having an external ear infection. Okay, so learn the tragus, learn this is known as the helix. Why you need to learn this is because you're upping your profile. Imagine you having that discussion with someone and you're not just saying, oh, it's an outer ear infection. You understand that that's the tragus, that's the antitragus, that's the helix, that's the triangular fossa. Your knowledge is just, people are going to respect you for it. People will listen to what you have to say. You're not just a pharmacist all of a sudden. You're this new generation of clinician that nobody has a name for, an advanced practitioner. You're an FY, I don't know, foundation, you're one pharmacist something. I don't know, but you need to learn that knowledge base. You cannot be treating and saying, yeah, it's an ear infection. With patients, it's fine, but you should know that's the helix, that's the lobule, that's the tragus. Just those three, that's it. If you want to be really fancy, then yeah, that's the triangular fossa, that's the concha, it's fine. But learn the tragus, learn helix, and learn the, I guess, lobule, because you could technically get outer ear infections here, known as cellulitis. And by the way, this is all cartilage, and we know what cartilage is. Cartilage is a type of connective tissue. 4 types of tissue: epithelial and endothelial. You know what we see in the heart? Endothelial lining is a form of epithelium. It's a specialized form of epithelium. So epithelial, nervous, muscle, connective. 4 basic tissues that form everything in your body. You name it, it's one of them. It's definitely one of them. Nervous tissue, muscle tissue, connective tissue, bone, red blood cells, everything. Search it up. It'll be one of those 4. It can't be anything else. Commit it to memory. This is the external ear. You've now know this is the vestibules. You now know that's the septum. You now know that's the nares. You now know you have the helix, lobule, tragus. You have the external ear, which includes this tube. You have the middle ear and you have the internal ear. That is your anatomy. For what you need to know is spot on. That's all you need to know for now. This is the tympanic membrane. This is absolutely mind-blowing. You need to understand this. I'm going to break it down for you to make it easy for you. What you need to know here is you have these bones here. And we're going to go through that, okay? These bones are basically this. These bones are this. I think I've got a better picture later on. These bones are these 3 bones here. These are known as ossicles. And what you can see here is that bone. Can you see how that bone's connected? Can you see? And when you go back, that's that bone there. Can everyone make that connection? That this here is known as the malleus or malleus, whatever you want to call it. And that's what you can see here. And that's why they call it the short process of the malleus. This is how your ear should look. It's pearly, it's gray. You can make out these landmarks. So landmarks are basically X marks the spot, just like on a map. That X marks the spot, this is the landmarks of the ear. If you can see these, it's good. It's good stuff. If you can see this, there's nothing, the ear is looking healthy, the ear is looking nice. The cone of flight is a physiological response. It's normally there. And at the top of my head, I believe the right ear, it's normally at 5 o'clock. So this is 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock, 4 o'clock, 5 o'clock. And in the left ear, everything flips. And you normally find this about 7 or 8 o'clock. And someone can just double check that for me, that's right. But I think on the right ear, it's this way, the way it's orientated. But this is what you're looking at the ear. And you can see that there is no connection here. In the sense that there is no, you can't get through this. You can't go through this. So if you've got a perforation here, something isn't right. Something is seriously wrong. And if you ever have a patient who's got a perforation, you need to refer that. Why you need to refer that, I'm going to explain to you. I'm going to explain to you why you need to refer that. why it's a red flag is not because you're not capable of treating it, because that can now develop into something a lot more serious. Imagine you had a perforation here, right? Imagine you had a perforation here. What do you think this is here? What's at the top there? Any guesses? Any guesses what's at the top there? Brain. That's right. So if you have an infection here, or you have a perforation rather, so now all of a sudden you have an opening, what is stopping this infection or this perforation from getting bacteria to go all the way up here and destroy this part here, and then go into the brain and cause, I don't know, inflammation of the meninges, which is just one of the outer layers of your brain? Search it up. If you don't know what meninges is, search it up. Never ever use a word without understanding where it is. Never ever be ignorant and start using words and you don't know what they mean. Don't do that. That, you know, if you get anybody's going to ask you, you're going to sound stupid. So please don't use words that you don't understand. If you're unsure, you can search it up. Okay, always do due diligence. But in theory, if you have a perforation, and how you know you've got a perforation is either you can look inside the ear or discharge. How long is that tube? 1 inch, 2.5 centimeters. It's not long. So if someone's having a lot of discharge, where do you think that discharge is coming from? It's not likely coming from the external ear. You can get a bit of discharge from here. It's probably coming from the middle ear. And if it's coming from the middle ear, and again, let's repeat it again. Outer ear is the pinna and the tube up until here. Anything that goes beyond this is known as the middle ear. Middle ear includes this space here and the eustachian tube, and the internal ear is this structure here. So we have external, middle, and internal. Learn it. So whenever I use these word middle ear, it makes sense. So if you have a perforation here, now you understand that if you've got a perforation there, that is something that has to be referred to. Why does it? How can you distinguish between discharge from outer ear or middle ear? By looking in the ear. That's how you distinguish. You literally get an otoscope and you look inside. You actually go inside and you have a look. Can I see a perforation? And if you can see a perforation, literally what you'll see is like an opening. You will see an opening. Go on Google, have a look at perforated eardrums, you'll see it. If you have a perforation there, wow, that's how you know. Secondly, for me, there's the other way that you know is keep looking at normal. The more normal eardrums you look at, the moment you look at something that's pathological, you know that's not normal. That's how you distinguish. If I had a patient who had, let's say, you know, they wake up and they say in the morning, my pillow is absolutely, has so much discharge. Yeah, often it's all clogged up and you can't see beyond. If it's really that clogged up and you can't see beyond it, you need to refer that. And think about it, as I've explained to you, if it's really that clogged up and you have a lot of discharge, that is most likely coming from the middle ear. The outer ear is only 1 centimeter. It's only 1 inch, 2.5 centimeters. It's virtually impossible to have so much discharge in the ear to block it up. It's just not possible. There's no way that the epithelial lining here can produce so much discharge that it blocks everything. That's got to be coming from the middle ear. Has to be coming from the middle ear. And that's what you have to think. But wait a second. Let me take a history. So this, and then again, it's in the history. You ask this patient and he goes, look, I don't go swimming. I don't have any pain when you feel on the tragus. When I look inside the tube itself, there's no inflammation in the external acoustic meatus or the auditory tube. But as soon as I put inside the otoscope, he goes, ouch, that hurts. You need to make a decision. And in any case, any discharge, you shouldn't be dealing with that, because you need to find out if it's a small amounts of discharge and you are happy that there's not a perforation, you can treat. If you really felt that actually I'm in doubt here, that might be a perforation, that needs to go to ENT. For me, does that answer your question? So just for everyone to understand, and I remember seeing my first patient had so much discharge and I thought, oh wow, that must be artery infection. And I remember Dr. Akib saying to me, Fahim, think about it rationally. How long is that ear, that tube? I said, it's not that long. And he goes, the kind of discharge that you're describing me, where's that coming from? That's got to be coming from somewhere. It can't just be coming from here. That discharge has to be coming from here. Remember, this is all, even it's a cavity, you've got, this is lined with mucus. It's going to have mucus. It's going to be having, you know, it's not just air, you're going to have other stuff inside there. There's blood vessels, there's all sorts of stuff. So if you're having a lot of discharge, and what I mean by a lot of discharge, I mean that it's literally, like you mentioned, clogged up, and you can't see beyond it. That can't be an outer ear infection. That has to be inner ear infection. So if you have discharge, the reason why you're referring is not because you're not capable of treating it, because you're thinking, wait a second, if that's a perforation, am I the right person to be making sure that's a safe or an unsafe, what we call infection? Would you ever empirically treat with oral meds and refer? Would I ever treat with oral meds and refer? It all depends on the history. I've done it before. I've had a patient who I was certain had a perforation. I did treat her with antibiotic with oral, referred it to A&E with ENT. They said, yeah, it's a perforation. I prescribed her with, I think it was Siloxane. I prescribed a Siloxane, referred her to the ENT, and they said, yeah, it's definitely a perforation. Thank you very much. We'll take it from here. And that was it. So yes, I have done it before, but it's not for everyone. You need to be careful. And you need to know your anatomy, you need to know your physiology, you need to know your pathology, you need to know your microbiology. If you don't know that, you should not be treating. And again, why take the risk of a 20, 30 pound and put that patient's life at risk? The fact that you've spotted it's a perforation and they're going to be hospital, that's good enough. That warrants them to pay that. You've done the right thing. So when you're charging, why did I use topical, not oral? Right. The reason why we choose topical, and I will leave this for you to do your research on, is because the evidence suggests that because it's very local, that the epithelial lining can easily absorb the infection, the antibiotic, and it works better locally because it's a very localized infection. If you treat somebody with oral antibiotic, you're treating everything, and there's chance of side effects, increased risk of resistance. That's why you normally see a lot of doctors go with local antibiotics because they work locally, unless the infection is spreading. Next time you have a patient who presents with a perforation, you'll notice that they give them Siloxane. Why? Because if you've got a perforation, they don't want ototoxicity, and it's a local infection. So whenever it's local, you normally go with topical antibiotics. When it's more extensive, if that disease was spreading backward and she had pain around here, and I could see that there's maybe an infection going here, and I felt, she's got a high temperature, I would have probably gone with oral. But again, this is not a case study on minor illness, otherwise we'll be here all day and we won't get it covered. But that's for the minor illness training sessions. But that was my point here about a perforation, and that's what you need to understand, that the human body is connected. The eustachian tube connects here, and that goes into the nasopharynx, which is the throat. So technically, if you have a throat infection, it can go backwards and can lead to a middle ear infection. I hope everyone's clear on that, because this will make it easier for you to do with when you're taking a history. I'm not going to go into an cholesteatoma. I think it's going to get really, really complicated. If you really want me to go through it, let me know in the Q&A, but I won't go through this. But a cholesteatoma is basically what we call a pseudotumor. Pseudo means it's not really a tumor. And it happens because you have this eustachian tube. It causes and it's hard to imagine, but it literally causes the middle ear to retract. Imagine if you were to retract the middle ear, and now all of a sudden you have an opening. Your body is always shedding skin. Your body is always growing skin. So every time you lose outer layer, inner layer would grow. And technically, if you have a space here, and this has become retracted, and you get a space here, this epithelial lining can grow into this space and form what we call a granulation tissue. Find out what that is. The granulation tissue. Basically, it's formed with dead cells, keratin. It's a keratin plug of dead epithelial cells, and that will keep growing and growing and growing, and it will literally erode bone, go into the brain. It can also go as far as backwards as destroying this bones here. It can also affect the nerves. Tell me something, if you had an issue with the facial nerve, what sort of symptoms could you possibly have? Any ideas? So I'll count till 5. 1, 2, 3, 4, 5. So loss of movement. Yeah, what you might have is we know the facial nerve actually innervates part of the face, and you can have a palsy, literally, where it will just drop. That's why whenever you're taking an ENT history, why do the doctors ask, have you got any asymmetries in the face? Because technically, yeah, Bell's palsy, technically what's happening is you've damaged the nerve. Can you see how beautiful it is once you understand what you're doing, why you're referring? As opposed to me teaching you red flags. Oh, this is a red flag if you have loss of movement here. That's a red flag if you have a loss of movement there. Why? You will never ever grow on that knowledge because you don't understand it. And teaching someone red flags when to refer, I think that's not I don't think it's the right way of going about it. But that's why it's really important. Why do you think you get hearing loss? Because the vestibular nerve, the cochlear nerve, balance, vestibular nerve, hearing, cochlear nerve, these are all connected. So anybody who has headaches, has becomes asymmetrical, has issues with hearing, has issues with balance. Now you understand why we need to investigate this a bit more. Why? Because the infection might be spreading so much that it's affecting the internal ear. That's how you start to understand why you refer this, why you don't refer this, why that's a red flag, why this isn't a red flag. That's why you do that. Is everybody okay to continue or not? Because there's still a bit to get through. I'm happy to finish it off. I can talk for as long as we talk to get it done, and I absolutely enjoy it. So if anybody's not able to continue, then it's going to be saved on the YouTube webinar anyway. So I apologize that it's taken slightly longer, but these things, it's difficult for me to kind of cover everything in an hour, but that's the understanding behind it, and I don't want to rush it. So that's the cholesteatoma. Referred pain. Why is this relevant? Why is it relevant to ask the patient, are they having any of the symptoms in the ear, nose, and throat if you're just having somebody who presents with otalgia? Why? Thank you. Because you have referred pain. Otalgia, search up what that means. Look at the nerve supply. You have the glossopharyngeal nerve that also supplies the tonsils and pharynx. So in theory, if you have tonsillitis, you can get an earache. The vagus nerve. The vagus nerve also supplies by the pharynx and the larynx. You have the auriculotemporal nerve. So technically somebody who has temporal arteritis. What is temporal arteritis? Not the veins. So arteritis refers to arteries. So temporal arteritis is normally you have inflammation of the arteries, and it's from the branch of the external carotid artery. So there's two arteries that come here, internal and external carotid artery. I won't go into too much depth, but you have we know these are temples, right? You've all heard that if you hit, when a boxer gets hit in the temple, it can be dangerous. And you have the temporal artery. In actual fact, you can actually sometimes feel a pulsation. If you get your two fingers and you put it just around this region, you can sometimes feel a pulsation there. But if you were to have inflammation of the temporal artery, you have something known as temporal arteritis. Who's ever heard of giant cell arthritis? I think it's arthritis, I'm not sure. Search it up. I think it is arthritis, yeah, giant cell arthritis. What ends up happening here is the patient will have inflammation of the temporal artery. And we know that the auriculotemporal nerve also supplies part of the ear. So technically this patient can present with you with earache, and you forget to ask the patient, are you having headaches? Are you having any visual issues? They could be having temporal arteritis and you've just missed it. You need to understand this stuff. There's something known as C2, C3 spondylitis, which is basically the nerves that branch off from the cranial nerves that branch off from here. Technically, you could have like a perforated disc where they get a stiff neck or can't move the neck, and that can also cause earache. Mind-blowing, isn't it? That simple earache doesn't always have to just be from the ears. It could be the mouth. You could have an abscess. You could have a dental infection. How mind-blowing is that? All of a sudden, an earache is not an earache. It could be any one of these. This is why you need to understand your anatomy, your physiology, and then pathology. How do you treat giant cell arthritis? Why do they give steroids? How do you treat a dental infection? Why do dentists give you metronidazole? What is it about anaerobic versus aerobic bacteria and abscesses? Why does, why did I have that patient on my LinkedIn video and I treated her with fluoxetine and I treated her with metronidazole? Why? Because it's your knowledge on pathology. Pathology incapacitates microbiology. You can't be treating antibodies. This is why when people ask me, oh, do you follow the guidelines? My understanding of pathology, I understand the rationale behind the guidelines. I don't need to go back and start reading guidelines. I can understand the guidelines because I understand my pathology, I understand my microbiology. Of course, I follow the guidelines. I don't need this PDF document to tell me what I need to do. It's a guideline. It's there to help me. It's there to guide me. Antimicrobial resistance, all up for it. I understand it, but I don't need a guideline to tell me why I prescribe what. I have a sound understanding of why I'm doing what. I understand why you give flucloxacillin for skin infection. It's caused by gram-positive. Why you give fluclox? Because it's more geared toward gram-positive. It's not what we call a broad-spectrum antibiotic. That's why we don't give clarithromycin all the time unless you're allergic to penicillin. I understand all that, and I understand how the guidelines work. It's not common. It's not rocket science. So if anybody pulls you up on that, oh, how are you following guidelines? You've got your own private practice. Your knowledge is what gets you there. So my knowledge of my anatomy, my physiology, my pathology, alhamdulillah, with the will of God is there. So I can understand if I have a patient presenting with ear infection, I know it could be referred pain. I'm looking for everything. I'm looking in the mouth. I'm looking in the temporal region. I'm looking in the mastoid area. I'm looking in the neck. I'm looking, does he have any pain here? Why? Because these nerves also go to the occipital region. I'm asking this guy all these things. That's the red flags, red flags. Is everybody clear on that? Is there anybody who's kind of a bit confused, like, I'm not getting this, or it's too much? I know it's a lot, but is there anyone who's really confused and like, I don't get this? Because I'm going to go into the history taking now. And this is not a minor illness class, so unfortunately, I can't go into all the different disease states, but this will help you kind of understand the background. I want to teach you how to self-teach. I want to teach you how to get from A to Z a lot quicker than what I did, which pick up textbook and read and spend hours and time when someone can get you there a lot quicker. So I'm guessing, Aisha, NQ, I don't know what NQ means, I'm sorry. Pharmacist, and I just wish you were my tutor. Thank you. Newly qualified, oh my bad, sorry, you know what? Yeah, well, I'm not, thank you. Again, it's not me, it's just with the will of God, but again, you could, again, people, this is why the reality is you can learn what you want. You can go pick up a textbook, but you cannot do it without someone mentoring you. It's impossible. It's impossible. It's virtually, today when I was learning about cholesteatoma, I read it in the textbook and it makes sense. I rang up Dr. Camille, I rang up Dr. Akib and said, Baijan, which means elder brother, I don't get this. The book is talking about, epithelial lining. It does make sense to me, but I just can't put the two together. Can you explain it to me? And when he explained it to me, I thought, oh man, that makes sense. Epithelial lining, mucus lining, got it, fine, move on to the next chapter. Otherwise, the trouble with the internet, there's too much out there. I remember once, and this is kind of like going off track. I remember once searching up a differential diagnosis for something and I typed in the wrong word. The different differential diagnosis came up. And I remember Dr. Akib absolutely slaughtered me for it. That stop searching the internet. If you're really unsure, ask me. Because you type one thing wrong, you're going to get a total different list of differential diagnoses. You're going to treat that patient unsafely. I don't want you to go start searching stuff on the net without confirming it because it's not safe. So that's that there. Now you understand history taking. Now you understand why it's in the history. So let's quickly run through. If I had a patient who presents with an earache, what am I thinking? I'm thinking, okay, earache. Let's look at the anatomy of the ear. We've got the external ear. We've got the middle ear. We've got the internal ear. Any one of these structures could be affected. Also, for him, the human body is connected. The ear is not separate from the rest of the body. Let me also think what I need to think at. I've got the sinuses, I've got the temporal artery, I've got the mouth, I've got the throat, I've got the scalp, cancers. Any one of these can be causing that infection. So now I need to take a history. Now my knowledge on these disease states will allow me to make the diagnosis. Then I whittle it down. So let's get into the process itself. 40-year-old male patient presents with earache. Okay. I wanted to actually have a colleague to demonstrate this, but they're all really shy. And they're like, no, 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 we don't want to be on the screen. I don't know why, but I don't want to be here. But this is going to be our patient, this chair here. Something that's really important, and I don't know if you can see this. If you can't see this, let me know. You never sit like this with a patient. It's not right. There's something known as bedside manner. There's something known as etiquette. You don't sit there as a male with your legs right open and you've got a patient sat there. If you ever look at the desk of a doctor, it's always sat where, it's always in this format where you have like a, it's like, yeah, here. It would be like it is here, like I would have someone sat on that side. They wouldn't be sat completely opposite. They would be sat on the side where I can listen to them and talk to them and say, yep, fine, we're having that conversation. You're not sat like this with your legs open. So whenever you see a patient, you never do that. Even when you go on to use the otoscope, very important for bedside manner. In actual fact, if I had a female patient, I would get her legs to point this way and my legs to point the opposite way. And then, so this is the chair. I would put her here and I would point like this, and her face would be, her ears would be in front of me here. And I would put the otoscope inside like this. So I'm not stood there like this with my legs wide open, like this. You're going to get yourself in trouble. So there is etiquette. Is everyone clear on this? Is that clear? I think it's clear. Yes, great. Okay. Okay, fine. So you always start off by looking at the patient. Anytime that I see a patient, the first thing that I do is I will look at the patient. I'm thinking, am I the right person to be dealing with this guy or this lady or this patient? I'm thinking, does this guy look unwell to me? Is there anything about this guy that I'm thinking, you know what, this guy's not well. He's huffing, he's puffing, he's sweating, he's anxious, he can't walk, he's clenching his fist. He just looks unwell. He's blue, like a Smurf. In actual fact, I wanted to make a point of, again, no disrespect to Smurfs. I wanted to make a point of this, but someone mentioned in the chat about cyanosis, which is basically, so research up cyanosis. Cyanosis is basically a condition where you end up getting a reduced supply of oxygen to the tissue. So if you don't get oxygen to tissue, you can start turning blue. Okay, fine, maybe I won't do this, but I will pay for your, I don't know, meal if you ever saw a patient who presented to your pharmacy with central cyanosis. I would pay you, I would take you out. If you had a patient who presents to you with central cyanosis, his lips are blue, his tongue is blue, his face is blue, that is not going to happen. Because for you to have central cyanosis, you're going to be extremely unwell because the body will protect all the central organs and shut everything else down. You might get peripheral cyanosis where your fingers become cold and your fingers become blue, but central cyanosis really, so it's really important that before you start mentioning stuff, you really understand what you're looking for. I would never ever say, oh, I'm looking at this patient, this guy's got cyanosis. If he's got cyanosis, what's he doing in my pharmacy? He's not going to be in your pharmacy. There's going to be a lot more that's gone wrong before he comes to you. Central cyanosis, think about it, central cyanosis. Central cyanosis is real, real deal. It's not a joke. You're not going to be having a patient. And if that does happen, then I guess I owe you a meal. Not going to happen. So fine, I have a patient. I look at him and thinking, you know what? And I'm going to use, because Farah's name is there. Farah walks in the clinic. I look at her and I'm thinking, you know what? Fine, I can deal with this. She's not looking unwell, in the sense that she doesn't look acutely unwell. She doesn't look like someone that I'm thinking, whoa, something is not right. I'm happy with this. So then what I do, I say, okay, I always introduce myself from the outset. Hi, my name is Fahim. I'm the prescribing pharmacist. They have the right to know who you are. They have a right to know who you are. You're not a doctor, you're not a nurse, you're a pharmacist. So I'll say, hi, Farah, or I won't say Farah because I don't know your name at the time. Hi, sir, or madam, take a seat. My name is Fahim, I'm the prescribing pharmacist. I'd like to start off by confirming your first name, last name, date of birth, age, get the details. Once I've got the details, I will then ask that patient, how would you like to be addressed today? What do you prefer? Mr. Ahmed, Mrs. Ahmed, Mr. Teletubby, I don't know, Mr. Smurf, who remembers Teletubbies? Whatever it is, Mrs. Aisha, Mr. Mo. Oh, call me Mr. Mo. Thank you, Mr. Mo. How can I help you today? Bang. Batman. Yeah, Batman, Mr. Batman. We could say Batman, or we could say Joker. Actually, anyone who's seen the recent film of Joker, it's a bit, I don't know. I went with my wife, and it's too much. I think that's too dark. That movie is just, at the end of it, you actually feel sorry for him, which is crazy. Like, why would you feel sorry for the Joker? He's a killer, right? But anyway, we won't go anywhere. We've got Batman here. So, Mr. Batman, how is I can help you? That's my outset all the time. I always do that. I always start off by introducing myself. My name is Fahim. I'm the prescribing pharmacist. I'd like to, oh, sorry. Thanks for the spoiler about the Joker. Sorry, my bad. If you've not seen it by now, don't watch it. Why would you watch it after 6 months that it's been released? Anyway, sorry. Anyway, let me get back. I need to focus on this. I've got the Batman here. So we've got this patient, and this patient presents to you. And I will start off by saying, my name is Fahim. I'm the prescribing pharmacist. Can I start off by confirming your name, address, date of birth, contact number, age? Sex is a bit of a tricky one because nowadays, I know, do you ask what is your sex? I don't know. What were you born as? That's for you to ask. You think about it. How can I help you today? Then what happens is, problem with my pointy ears. Actually, somebody made a point. Apparently, I've got really small ears. You've got pointy ears. Fair enough. There's a condition that does have pointy ears. I think they're bat's ears or something. I think it's something like that. I've got small ears apparently. I don't know. But yeah, I've got a problem. You've got a problem. So I've got a problem with my pointy ears. Right. Now, if this patient mentions to you, I've got earache, the first thing I'm thinking is my differential diagnosis. Straight away, I'm going to let him say his piece. I'm going to let him do his thing. But I'm thinking, what is the differentials? Straight away. It's the first thing that goes in my mind. Earache, what's the differentials? Yeah, so we can list them. So you have otitis externa. So let's think about the anatomy, right? So you could have an infection of the outer ear, otitis externa. You could have an infection of the middle ear, otitis media. You could technically have an infection of the throat. So it could be tonsillitis. You could technically have a dental infection. You could technically have you could have an infection of the arteries. What else could you have? Trauma. Could be trauma. Even without you having sinusitis, well done. Could be sinusitis, spot on. So can you see, just by you understanding your knowledge, cancer, all of a sudden, you're now breaking it down so beautifully that it's all making sense. You already know the differentials. You already know the differentials. You're a pharmacist. Trust me, you know the differentials. And you're all mentioning some wonderful stuff. That's spot on. So that is my mindset. If a patient presents with a sore throat, bang, I'm thinking, what are my differentials? As soon as he mentions sore throats, I'm thinking my differentials. Then I'm thinking of some serious stuff. What can I not afford to miss out? Out of everything I've mentioned to you, you already know mastoiditis. Aisha, can you explain to me what's the problem with mastoiditis? What's the problem if the infection spread up to this part of the bone? Can you write it down? What structure lies just at the top? Spot on. Now you understand. If they've got pain here, you're thinking, wait a second, why have you got pain there? Something's not right. That infection could be spreading. Well done. If the patient has issues with their eyes, vision, which we know all the different arteries that are connected, can you see how serious that is? Oh, another one. Tell me which condition presents with burning and it's to do with like nerves. And you can start off with like a burning sensation. Which condition? Shingles. There's something known as, I think it's Hunt syndrome. I think I've written it, I can't remember. Something hunting syndrome or something it's known as. It's a special kind of shingles. Yeah, Ramsay Hunt. It's a special kind of shingles, which basically is because of the infection of the facial nerve. You've just figured it out. You've just figured it out by anatomy without you reading a textbook and memorizing stuff. You already know that you can technically, a patient can present with shingle, Ramsay's Hunt. You've literally just broken it down. You've broken this case down so beautifully. You don't need to sit there thinking, oh, you know, I need to learn all these red flags and red flags and red flags, but not understand it. You understand it all. That's spot on. Remember, this is not a lesson on minor illness. So we've already literally been an hour and a half. So I'm not going to go into all the disease states because that will take too long, but I'm just breaking it down for you. So my name is Fahim. I'm the prescribing pharmacist. Name, address, details. How would you like to be addressed? Call me Mr. Ahmed. What is your, you know, how can I help you? I've got earache. Sorted. Okay, what happens after that? You're thinking at the back of your head, your differentials. Fine, got that. Now what ends up happening? What? Sorry? So what ends up happening now is we move to the next slide. Can you take a picture of this? Can everyone jot this down? This is what I follow all the time. That's what I've broken it down to you. Is the patient unwell? Remember, I'm always inspecting first. But after that, we start to put the otoscope and start to feel and touch. You always look first. I'm watching how they're walking in. Is there any airway problem? Is there any breathing problem? Is there any circulation problem? Does this person look unwell to me? Start off by giving the intro. Take his detail. Is the patient comfortable? Confidentiality. Confidentiality. You should always mention to them that any discussion that we have is confidential in line with our confidentiality policy. Make sure you have a policy, because you're going to sound like a silly person if you don't have a policy and they ask you, what's your policy? Yeah, you don't want that to happen to you, trust me, it's not nice. So you need to have a policy. How can I help you? I've got earache. Fine, let him say his piece. He's got earache and I've got hearing loss. Two different symptoms. You have to treat them separately now. Deal with the earache, deal with the hearing loss. This person has got a chief complaint of earache and hearing loss. I've got earache and headache. I've got earache and vision issues. Two separate conditions you have to treat now, because people come with symptoms, people don't come with diagnosis. Some do, but it'd be fun if a patient goes, I've got shingles, bang, treat. I've got otitis media, bang, treat. No, he's gonna say, I've got earache, I've got discharge. You have to break it down that, okay, these are the symptoms. Which symptoms relate to what disease state? Once I've got my differentials, I'm thinking, what are my alarm features? What are my alarm features? What am I not comfortable with treating here? Not because I'm not competent, because I just think I'm not in the right position to treat this. So, discharging here. If there's discharge, I need to think. And what kind of discharge? Is it blood? Is it pus? Does it smell? You're thinking discharge? No. What else can't I deal with? You can't hear at all. Something else I've got to deal with separately. You could treat that, but we won't discuss that at the moment. Pain that goes to the back of the, you know, this mastoid bone, mastoiditis. Headaches, visual loss. I look inside the mouth and I see an abscess. I have a look inside the throat and he's got, you know, swollen tonsils. Which then I always think, okay, I've got my differentials. I know my serious ones I need to rule out. I'm always thinking of stuff that I have to rule out. Then I go back and look at which systems do I need to investigate. There is always, always, always at least two systems that you need to investigate. In this case, it would be the ear and then the nasopharynx. Always two systems. If the person comes to the throat, you should always be thinking, I can't just inspect the throat. I must inspect something as well. Somebody comes with chest pain. Which two systems would you investigate for chest pain? I can think of three. It's getting late. You're probably getting tired. But if I was to investigate chest pain, yeah, cardiovascular system, the cardiovascular system, respiratory system, and you could do the gastrointestinal system. You could technically, can you see the systems? Why? Because we know that chest pain isn't always the heart, could be the lungs, could be referred pain. So always two systems. I'm always thinking I have to have two systems. I cannot just inspect one system. I don't care what it is. Possibly MSK, spot on. Could be MSK, well done. Yeah. You're thinking, okay, I might need to investigate MSK. What if it's shingles that he has? You look inside, oh wow, you got a rash. That chest pain that you're having isn't chest pain, it's a burning sensation, is this. And Monam, spot on. This is it. This is beautiful. You guys are getting the hang of this. This is easy. This is not hard. Just with the right training, you can do this. So this is what I would do if I was taking a history. I'm going to run through this. So I let the patient tell the story. I ascertain the time course of the ear pain, how long they've had it for, why? Because if this patient presents with earache and he's had it for 2 weeks, we might not be in the best place to treat that. Because the earache's been going on for 2 weeks, that might be chronic. Anything more than a week and a bit, I think is chronic. Chronic in the sense that that's more than acute now. That's been going on for a long time, and you've not even had any treatment, and it's not gone within 1 week or 2 weeks. I'm not sure about that. Associated symptoms, bang, you got it. What other symptoms do you have? What makes it worse? What makes it worse? Oh, temporomandibular joint dysfunction. Has anybody heard of TMJ? So temporomandibular, you have basically your jaw connects in this socket here, which is known as the temporomandibular joint, and it's mainly involved in eating, and you have this muscles of mastication, like the masseter muscle. And what can end up happening is people, when they grind their teeth and they're stressed out and they keep using that muscle again and again, that can cause referred pain. Why does it cause referred pain? Because we know that the nerve supply to the ears is so complex that technically anything here can cause pain there. So you could also have what we call temporomandibular joint. Again, you now have to have the understanding of the pathology to be able to treat them. Just by knowing a list of differentials and not understanding what symptoms they are, how they progress, how you differentiate, you still can't treat. So you have to know your anatomy, you have to know your physiology, you have to know the structure of taking a history, you also have to know the pathology. Then you can treat. Pain unresponsive to simple analgesics, or that is burning or lansating in quality, may be nerve related. We all know about nerve pain, right? That's straightforward. We all know about nerve pain. That's straightforward. Burning sensation. And I remember I always had this really difficult question. How do you differentiate between herpes simplex or a simple, like, how do you differentiate between a simple cold sore and what's that infection that you can get here? I'm going blank. Who knows is that infection you get on the lip? Children get it all the time. It's known as impetigo. Impetigo. How do you differentiate between the both? Is your understanding of pathology that, wait a second, if it's herpes simplex, it's normally, you would have a tingling sensation. It's normally nerve related. They both will present with a bulla, will present with this vesicular, but normally herpes or cold sore normally can have this burning sensation. Secondly, it's not normally, with a staph infection, again, staphylococcus. Is staphylococcus gram positive or gram negative? Well, hey, equals positive. I'm guessing that's what, okay. So Aisha, I don't understand the temporomandibular joint bit. Okay, so you have a joint here, which is known as, it connects your jaw. Sorry? Yeah, I know, it will be nearly done. You have the joint here, and this connects to this temporal bone, and it's known as the temporomandibular. This is the mandible here. This is the mandible, which is the jaw, and this is the temporal bones, and together they form the temporomandibular joint. So if someone has any pain here, so when you ask them to open their mouth and they can't open it in full, or if you ask them to squeeze their teeth to go, it hurts, that could be the cause of the earache. The reason they're having ear infection, not an infection, sorry, the reason they're having otalgia, which is earache, isn't because they've got an infection here, it's here. Aisha, does that make sense? On the basis that you've ruled out everything else, that it's not otitis media externa, we haven't got this middle ear which is inflamed, or you can't see discharge, you think, you know what, there's nothing wrong with your ear looks marvelous. So let me now investigate the other parts of the body. And he goes, look, when I open my mouth, it really hurts. Could be an abscess, or it could be temporomandibular joint dysfunction. Is that clear? Oh, how would you treat temporomandibular joint dysfunction? Honestly, normally you can just do that by resting it, or analgesic and certain painkillers. That's a whole separate discussion. But normally, if you were going to treat TMJ, depending on what the cause is, but if it's just literally them keep grinding their teeth and being stressed out, just tell them to stop doing that. But if you type in temporomandibular joint diagnosis and treatment, you'll get the answers. But normally, depending on what the cause is, that's how you treat, because the TMJ is a disorder of muscles and skeleton. So it could be technical erosion of the mandible that can be causing it. So it's a lot more in depth. Temporomandibular joint disorder is like an umbrella term. It's an umbrella term that has a lot of different disorders. So it's not that straightforward. But if you just literally search it up, you'll find out. You can go into the pathology of it and you'll understand it. Straightforward. Right, 3 factors that allow you to distinguish between numerous pain. So fever, presence of upper respiratory tract infection, and age. Children with earache, based on probability, are normally always tend to be middle ear infections. Why? For next time's webinar, someone needs to find out why. It's something to do with the anatomy. Children anatomy equals otitis media. Find out. Find out what it is about children in the anatomy that puts them at risk of developing otitis media. There's a reason for it. Again, your understanding of anatomy makes it easier. Fever is a sign of infection. Presence of an upper respiratory tract infection could mean that they're having otitis media. So I'm always thinking of these things all the time. These were my list of differentials, by the way. No. It is to do with the eustachian tube. It's not to do with it being large, or not totally to do with it large, but it's to do with the eustachian tube. Find out. And it might be a combination of 2 or 3 things. Large doesn't come to my mind, but it's something else. Okay, we need to not answer the question. You can't answer the question. I said next time. We can't answer the question. Is everybody happy? Yeah, close but no cigar, but I think, you know, Manoon's on the right track. So can everyone, that was my differentials. Otitis media, otitis externa, could be a boil or a furnicle. What did I mention about, I didn't mention this. You know the outer third, or the outer third of the ear, we know we've got hair in there. So what's stopping that hair from being clogged up? Make sense? Why do we have hairs? Why do we have hairs there? Just like we've got hairs in our nose. You basically have hairs because you don't want to let small objects get inside the ear. You know what, I'm just saying thank you for everyone staying. I can't believe that we've still got the same amount of people. 99% of you lot still here. Wow. Either I'm doing a really good job or either you're being very polite. It can only be one or the other. So this was my differentials. That's how I would deal with an earache. I'm thinking of any one of these. And it's your understanding. Now you might ask me, oh, Fahim, how do I know between bacterial, fungal, and viral? There is a way you can differentiate it. If you read up a pathology textbook, you'll find out why. But we'd be here all day. Otherwise, we'd need another hour. And I am more than happy to do it, but it's going to get too long. And it's really weird because my wife's actually calling me thinking, what's happened to him? And she knows when I'm into the zone, then I'm in the zone. But I listed these. I've been through most of them with you. So is that okay? Is there anything here that you don't understand? Is there any word here that we've not gone through? have a good look. Is there anything on there that I didn't mention? Eczema, technically, can. And that's like just any other eczema. Okay, great, fine. Everyone is happy. Nice. Otitis externa, quickly going through it. What are the risk factors? Why is swimming in high humidity a risk factor? Why? Why is it a risk factor? Any ideas? Why is it that when you ask a patient and you think that they might have an outer ear infection, you ask them, do you swim? Or have you been in a jacuzzi? Why? What about the moisture content? What about the moisture content? Risk for what? Yes, 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 yes. It's the bacteria. Bacteria love it. And it's a particular type of bacteria in the ear that you'll find. And it's Pseudomonas aeruginosa. Pseudomonas aeruginosa. Okay, whoever answers this in the next 2 seconds gets, actually, I don't know what you get. Is Pseudomonas aeruginosa gram positive or gram negative? Well, hey. Oh, wow. Shoaib was on it. Literally, Shoaib did not mess about. Shoaib literally just had it spot on, bro. You didn't even take a second to answer that question. But yeah, it's gram negative. So what antibiotics, mind reader, yeah. What antibiotics would you treat it with? Come on, pharmacists. All that pharmacology that you've studied. What do you reckon? What antibiotic do you think we could treat this with? So it's any antibiotic that would cover a gram-negative infection. It's going to be something like, you could go with amoxicillin, doxycycline, works on ribosomes. You can go with amoxicillin. You could go with clithromycin. You could go with ciprofloxacillin. Anything that would cover those. Penicillin, spot on. And that's the rationale for it. That's the rationale for it. Because you have this gram-positive, and fungal infections. Has anyone ever come across doctors prescribing canesten in the ears? You must have. Thank you. Yeah, you must have. There's no way that you could have had doctors. Yeah, that's right. That's the reason why. Because they might think, yeah, I don't know if it's off-label. I can't remember. And aminoglycosides, yeah. What did I mention about aminoglycosides and perforations? Ototoxicity. Off-label. I'm not sure about if it's off-label. You'll have to check that. Again, normally if you have like this presence of spores and this smelly discharge and it's whitey, thicky, similar to thrush. And it's unresponsive to treatment, might be fungal. And the only way to diagnose it properly is by having sending a sample. There's no other way. It's impossible. You could on physical examination have a think, what, I think that might be fungal, and you could treat it, but there's no 100% way of doing that. So normally, that's, if your question is going to be next, you're going to ask me, how do you know if it's fungal? That's how you know. There's a way that you can do that. And there's acute localized. So otitis externa means localized infection, diffuse infection where it goes all the way through the tube, and a chronic infection. Acute localized infection could just be boils. And doctors, what do you think they'll prescribe for the boil? Which antibiotic? Yeah, Fluclox. That's right, Fluclox. Do you think you're going to go with oral antibiotics, or you could possibly prescribe a cream for this? Yeah, so for this particular case, it's going to be oral, and you would go with oral antibiotic. What lining is this? What lining is this? This lining here. What lining is this? This is epithelial lining. The relevance of this epithelial lining is that if this lining was to continue here, you can get this keratin plug, and you get this cholesteatoma, and it's a growth. It's like a cancer, but it's not a cancer. It's a pseudo cancer, pseudotumor, I think it's known as. A pseudotumor, and what it can end up doing, it can end up basically, going backwards and destroying cells. This is dangerous stuff. But that's basically otitis externa pretty much covered for you. I've just done it as a small slide. Otitis media. Otitis media is all to do with this eustachian tube being blocked up. Pressure then goes onto the middle ear. And what you normally find is this bulging middle ear. It's red, it's inflamed. They would have had a history of an upper respiratory tract infection. And it normally results from the bacteria that goes from the eustachian tube all the way to the middle ear. Causative agents, Streptococcus pneumoniae and Haemophilus influenza. Streptococcus, again, is gram-positive. H. influenza is gram-negative. Easy peasy. These are viruses, so it could be viral as well. So for somebody presents with earache, they've got a cough, they've got a runny nose, maybe it's viral. You might not want to treat with antibiotics. You're looking at the tympanic membrane. If they have any perforation, you now understand that these perforations are serious. In actual fact, unsafe CSOM. So search at what are unsafe. And CSOM stands for chronic suppurative otitis media. And there are certain perforations that are safe and they heal spontaneously, nothing to worry about. But again, you will always refer to ENT. Unless you are an absolute, unless you are, unless you're extremely gifted and you have a lot of knowledge and you've seen a lot of these cases that you can, diagnose like an ENT consultant or a surgeon can, fair enough. But you shouldn't be dealing with any sort of perforations because you'll miss it until it goes too far. And that's the advice that I was given by Dr. Akib as a consultant. He literally said, unless you know more than me, I don't want to answer that question. I was going to say, okay, fair enough. I won't answer that question, but unless you know more than me, how the hell are you going to diagnose that person with if it's safe or unsafe? But that's the answer. So that's otitis media covered. Serious diagnosis, temporal arthritis, we've been through it. Okay, so anybody who's over the age of 50, acute, subacute headache, pain in the temporal area, jaw claudication. What's jaw claudication? What's jaw claudication? You can put it on Google. I'm sure you can search it up. I'm going to leave it for you guys to find out. Jaw claudication. Pain on movement, yeah. Brought or aggravated by brief periods of chewing and relieved by resting jaw, prompt treatment, otherwise blindness. Why do you think you're going to get blindness? Why would you get blindness? Why would you get blindness? Yeah, but there's something else. It's the optic artery. So, your body's related, right? Everything is related. Everything is related. So that is that. Mastoiditis, I've been through with you. That's what it looks like. That's another red flag. Must be promptly recognized if patients report becoming ill. Infection can destroy temporal bone. And that's the history taking. That's literally, I've just broken it down for you. Onset, when it started, if it's more than 10 days, it might not be a simple case of otitis media. If they have an upper respiratory tract infection, possibly otitis media. If it's been going on for a long time, it might not be, you might not be the best person. I think that's supposed to be barotrauma, not bayotrauma. I think it's barotrauma. That's, you can search up what that is, barotrauma. And that's to do with basically when you have change in pressure and it can cause this damage of the middle ear, because if you were to, for example, when you go on a plane and you have to blow like to equalize the pressure, so you could technically go scuba diving and that pressure increase pops the drum itself. So that's barotrauma, but you can search that up quickly and find out what that is. So you also want to ask them how long, you want to ask them the characteristics. Is it severe? Is it deep within the ear? If it's deep within the ear, possibly otitis media. If it's like a cloggy feeling, it could just be earwax. If it's burning, knife-like, could be neuralgia. If it's bilateral, possibly otitis externa, apparently gored because of the vagus nerve. Temporomandibular joint dysfunction. If there's any aggravating factors that makes it worse, Neck stiffness, I mentioned about the cervical, what they call cervical cranial nerves. C2 is C3, ear plugging, temporomandibular joint, infected third molar. That's why you take a history. It's really associated symptoms, discharge, eustachian tube, barotrauma, any allergies, hay fever, because it could be sinusitis. Is this clear for everyone? Is this clear? Is there anything on this that's really confusing you guys in terms of taking a history, how you actually do this? So if I had a patient, I'd ask him, okay, tell me about this earache. I would ask them literally these questions, and you can review them and watch it again, but literally these, when did it happen? It happened yesterday, fine, I'm happy with that. If it's more than 10 days, I'm thinking, oh, long time, I'm not happy with that. That's taken a long time. And remember, I've got a slide that I've missed here, which I think I've missed a slide here, so I do apologize. I've missed a slide. Yeah, crackling and gargling. So crackling, you normally find that in otitis. You find that in otitis media with serous otitis media, which is literally where you have the eustachian tube becomes blocked up, but it's not infected, and you can get this crackling and this sensation. So you can end up having that and a popping sensation would come with serous otitis. So it's not an infection; it's the eustachian tube which connects the nasopharynx to the back that gets blocked up. So this tube here, the nasopharynx that goes here, and it just becomes blocked up, and that just increases pressure there. So that's where you get this crackling, this sensation. But you know, you want to ask that patient how long you've had it for. A couple of days, fine. Treatment be what's nasophan? Is that beclometazone? You know, this is, you know, I can't believe I'm a pharmacist, but I can't even remember half this stuff now. Yeah, is treatment nasophan for serious otitis externa? I'll leave you to find out. So otitis externa is managed slightly differently to otitis media because it's not an infection. It's to do with the eustachian tube dysfunction. So you can search this up, serous otitis. And they normally use, you might have seen those people have those, what's that balloon that you can put in the ear? What's it called? What's it called? Yeah, grommets, otovent, there you go. Yeah, that's the otovent. So have a look at serous otitis. It's different to otitis media. And I always like to use OLDCAART, 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 onset. Where's the pain? The duration, the characteristics, the associated symptoms, aggravated symptoms, relieving and treatment. That's what this basically is. So I'm asking the, if I go back, so onset, 10 days or less, I'm thinking these. That's the O. Location, where is the pain? It's the outer pain, it's here. It's not going to be in them, it could be something localized. Oh, I feel it's inside, fair enough. Duration, how long has it been? I don't understand how the ear pain can cause GORD. That is, I think that's to do with the vagus nerve. I think it's to do with the vagus nerve, but you can search that one up. I believe it's to do with earache and the vagus nerve. I believe it's the vagus nerve, which forms part of the glossopharyngeal nerve. Remember, your body is connected. You'll be surprised. You could technically have pain in the stomach, and it could be related to the ear. So just keep an eye on that. You know, everything's there, but double check that for me. But I believe it's to do with that. But you can, I believe it's the vagus nerve. Let me have a look. Gordon and otalgia. Just going to quickly check this. Yeah, so a variety of pulmonary ear, nose, and throat symptoms and disorders are considered to be extraesophageal. So it could be related to that. There's something on here. It's to do with, I think it's to do with the vagus nerve. You can have a look at that, but it can manifest with that. But it's to do with the vagus nerve. But you can have a look at that and look at the, and again, it have to do with the. It's all going to do with the actual, the nerve, because remember, every part of your body is connected. So there's, you know, so then after that, what we look, you know, if there's a burning sensation, if you're having a burning sensation characteristics, because that might be neuralgia. If it's bilateral, it could be otitis externa, temporomandibular joint dysfunction, I'm thinking about. Aggravating factors, chewing, temporal arthritis. Why? Because the temporal bone. And if you chew, you'll feel this muscle, the temporal muscle, move. And that can put pressure on the temporal artery. You get pain. Neck flexing could do with the cranial nerves. Ear pulling, otitis externa. Pain worse when swallowing, elongating styloid process, have a read of that. Temporomandibular joint dysfunction, could be GORD, pain worse in the morning, have a look how GORD is related to it. Hot and cold food, infection of the teeth, and pain provoked by light touch, neuralgia. Could be just literally terminal neuralgia. And these are aggravating factors that could make it worse. So you can read this, have a note of that. Associated symptoms. Fever. Do you grind your teeth? Perforation. Wow, endocarditis, tooth pain. Really? Pain decrease. There you go. Endocarditis can cause tooth pain. Is that what you're saying, South Korea? Perforated eardrum, hearing loss. Why can you get hearing loss? Because it's to do with the cochlea and it's to do with the vestibular apparatus, which we spoke about last time, which is basically these structures here. Technically, they can get infected as well. Then what we have is relief. Have you been putting something inside the ear? The treatment. Are you diabetic? Something with diabetes. You've got to know something with diabetes. It's known as diffuse. I think it's diffuse chronic otitis, necrotizing otitis externa. Necrotizing otitis externa. It's literally where the infection will destroy the external canal and then can start to destroy bone. It's more common in diabetes patients. So if you have a diabetic patient who's having this pain and this recurring otitis externa, you need to be thinking about this. Could it be this condition that he mentioned? And do you swim? We've discussed that. Scuba diving, barotrauma, weight loss, tumors. Persistent, again, pain at night is always a scary one. Pain at night. And then you're looking at immunocompromised. Again, immunocompromised patients, again, that's a risk factor because you're immunocompromised, easy can get infections. And it could be, you want to make sure it's chronic. And that's basically it. That is everything in terms of history taking covered. I would recommend that you always follow this set structure. I'm going to go back to this structure and you can ask me any questions that you'd like to. We do have a short time. A lot of you people ask me what training I do and what training we offer. So it might be worth me quickly going through that. But can you all take a picture of this slide? I'm going to show you the slide. Or you can watch it, this slide here. So you have the PC presenting complaint, history of presenting complaint. You're asking for onset, location, duration, characteristics, aggravating factors, associated factors, relief treatment, past medical history, risk factors, pre-existing disease, family history. Wow, yes, yes, it can. I read that. Yes, you're right. There you go. Who would have ever thought? Then you look at social history, occupation, smoking, alcohol, drug history, travel history, sexual history, and the review of systems. These two slides, jot them down. You asked me about kind of what training that we offer, and a lot of people have got in touch. Fahim, what training do you offer? I wonder if I can open up something quickly here. And oh God, I don't think I have it there to show you. But there you go. Can everyone see this? I think you can. So basically, we teach you all clinical skills, from you wanting to learn how to take a history properly inside out, from you wanting to learn your minor illnesses inside out, from you wanting to understanding blood results. We treat everything. In actual fact, I'm developing a mastery program next year, and it's going to happen in January, which will basically, it will start from all the anatomy lectures, all the way to pathology lectures, all the way to physiology lectures. It will also encompass these courses as well, and you'll get hands-on training. And I think it's like what I call a masteries program. Within 12 months, you'd have mastered pretty much everything. You'd be able to know 10 to 20 conditions easily and take it from there. That is literally how you'll be able to use. So I'm getting these questions and I don't understand how ear pain can cause GORD. So I'm going to let you look that up, Shrib, and you can answer that next time at the webinar. Find out how you can actually link between GORD and ear pain. You know, how the abdomen can be related. And it might not just be, look at the type in abdomen and earache. Oh, I've answered it. Oh, my bad. Okay. Is MacLeod's a good book to use? Is MacLeod's a good book to use? Any textbook is good, I guess. But the question is that MacLeod's is good, but the only trouble with it is with any book is you still need access to someone to teach you. You can definitely pick up a book. That's what I honestly speaking, I did pick up a book. I picked up anatomy. These are the books that I picked up. Gray's Anatomy, 1,000 pages. I picked up a physiology textbook, which was, I think it was, what's it called? The physiology textbook that I read was, my physiology textbook that I read was, it was called Guyton and Hall. Again, another 1,000-page textbook. The pathology textbook that I read was a pathology by Harish Mohan, and that's about a 1,000-page textbook. And then I read a book on microbiology, and then I read on histology, my medical biochemistry. The medical biochemistry book was a 1,000-page textbook. So it depends. You know, the internal medicine book I think it's a 6,000-page textbook. So you can definitely learn this. That's why I'm developing the mastery program, because certainly you can learn it on your own, but it's going to take a long time. It's going to take a long time. It's like, that's why pharmacy takes 4 years. That's why medicine takes 7 years. But certainly I'm developing this course for everyone that within 12 months, with your lectures on anatomy, lectures on physiology, lectures on pathology, lectures on microbiology, webinars, then you have practical sessions, then you have mentoring, then you have history physical examination, bang, you guys will be teaching. That's what'll be happening. That's exactly how it's going to happen. So those who have attended today, I'll send you the course outlines that we have if you're happy with that. And if anybody doesn't want that, let me know in the chat or send me a message that, you know, because with this, all to do with this consent and so forth, so you have to get consent. But I think if anybody has any other questions, let me know. Otherwise, we are done. And if you were happy with it, that's my job done. Any questions? Can you get a copy of the slides? I can't send you a copy of the slides, and there's a reason for that, because I've got pictures and stuff on there, and I don't think I'll be allowed to send you a copy of the slides, but you can watch it on YouTube, because I think it's to do with something Sadiq brought to my attention, so I can't unfortunately send you a copy of the slides, but you'll just have to go back on YouTube and make notes, unfortunately. Sorry, Samra, for that one. Any other questions? No problem, thank you. Perfect. One of your colleagues actually asked me a good question as a newly qualified pharmacist, what I should be doing. And I made a point of the Boots, what they've started. What do you reckon you should be doing? Yeah, thank you, Nisa. That's important, because one of your colleagues had got in touch and said that she's gone on training by a particular provider, and it's all about red flags. This stuff about red flags, it doesn't go down with me. You know, I'm not a fan of this red flaggy stuff. Oh, that's a red flag. 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 Why is that a red flag? What's it about? It's a red flag. Why can't you treat it? Why can't I treat it? Explain it to me. I don't like teaching like that. I think you're leaving people like kind of half-hearted and in the center, and I don't think that's right. So, you know, we teach on all our training, from clinical history, physical examination, hands-on training, mentoring, how to set up your private clinics, everything we teach you. CQC registration, the whole lot. Everything we teach you. So there's literally nothing that, oh, have we got any question on, have I got anything on the live? Oh wow, there's questions. So there's literally, ouch, so I can hear myself. Nothing there. I like the way you teaching. It's how Aston Uni approached IP. Your webinars are refreshing. Yeah, I mean, you know, if you're going to be teaching someone, it should be done properly, right? You want to respect the human body, give it the respect that it needs. And this is nothing. This just, you know, you got to appreciate it takes a doctor 7-8 years to get where they are. You cannot expect in 1 hour for me to teach everything. But next year with that mastery program, 12 months, you guys are going to be done. You guys are going to be teaching. Anybody signs up to it, you guys are going to be teaching those anatomy lectures. And anybody who wants to individually, you know, we're looking to set a price for pharmacists for anatomy and physiology lectures that they're 1.5 hours long. But you know, it just saves you time. The other approach is that you pick up those 1,000-page textbooks and learn yourself, which you can do. Nothing's stopping you from doing that. But the reality is it takes a long time for you to get to A to B when someone can get you there a lot quicker. And everything you're not going to understand. You're still going to have to ask questions. I don't care how smart you think you are. I think I'm quite smart. And even then I have to ask questions because the books can only teach you so much. So these training programs, are they to support IP? No, they're to support every single pharmacist. I would suggest that you do eventually become an IP. It's the future, it's where it's going. There's going to be no way around it. So it's something you need to be doing, but these courses are for everything and anything, for even anything. You just upskilling yourself. So the wrong way to go about it is to do your IP and then get clinical skills. That's wrong. That's how I did it. It's not the right way. The right way to do it is you get your clinical skills, then you do your IP. So you've not spent a year doing your IP and you can't prescribe. Just like that GPHC survey 2018. Have a read of it. Have a read of that GPHC survey 2018. It's the same problems, because pharmacists and nurses have gone on to say, okay, let me go get my IP. And then when it comes to prescribing, things don't work out. Why? So why they don't work out is because you've not given the human body that appreciation it needs. You're not giving that human body that, you know, it doesn't help. You know, you need to give yourself that chance. So I would certainly have a read of that as well. Any other question? Anybody drank this Virtue sparkling energy water? I've never drank this. I don't know if it tastes nice. Let's find out. Yuck. I'm not going to be having that again. Forget that. Just stick to water. Are we done? Cool. Great. No questions. Perfect. Thank you very much. Everybody have a great new year. For those of you who are celebrating Christmas, have a great Christmas. And you are more than welcome to speak with me directly. Get in touch with me if you've got any questions or any concerns or anything you'd like to discuss. Do give your honest feedback to Sadiqur, please. You need to do that. Otherwise, I can't improve on my skill set. I can't improve these webinars for you guys. So I don't care if it's negative feedback, but no feedback is negative. It's constructive feedback. We're all one family, right? So I don't have an issue if you can completely slaughter it and tell me this is not right. Your feedback is a must. So thank you, everyone. And for those of you who want to go watch Joker, can now go watch Joker and have a good evening. And yeah, peace out. Thank you.